all experienced an earache, right? That sort of dull throb, maybe your hearing feels a bit off. Annoying, yeah. Uncomfortable, sure, but usually, it clears up without too much drama. You might grab some pain relief, maybe see a doctor, get some drops, and you're pretty much back to normal. But what if, what if that seemingly standard earache was actually the start of something way more sinister? Something that turns a localized infection into a condition that's incredibly complex, really challenging to manage. Well, today, that's what we're diving into, a condition called Malignant Otitis Externa, or necrotizing otitis externa. The name itself sounds pretty serious, and honestly, it lives up to it.
It really does. It's quite a stark example of how something familiar, like an ear infection, can escalate fast into a serious medical challenge that needs, well, a really deep understanding. So our mission today for this deep dive is to pull out the key insights from the sources you've shared on this specific, pretty aggressive condition. We'll look at who's most at risk, how this infection takes these surprising, quite invasive paths through the body, and also the sophisticated ways it's diagnosed, and thankfully how treatment has evolved and become more effective.
Okay, so we've kind of hinted it's more than just a regular earache. Let's really unpack that. Let's peel back the layers here. What is malignant otitis externa? What actually defines this condition?
Right. So at its core, malignant otitis externa, let's call it MNOE. It's easier. It is an inflammatory condition, yeah, but it's specifically driven by an infection. And the main culprit, the bacterium usually responsible, is Pseudomonas aeruginosa. And here's the crucial part. It doesn't just hit anyone. It tends to target specific vulnerable groups. Most often, you see it in elderly people with diabetes or in individuals taking immunosuppressive drugs. That underlying weakness in their immune system, that's really central to why this thing gets so aggressive.
Okay, so if it can start out looking like maybe a common outer ear infection, like swimmer's ear or something similar, how do clinicians tell the difference? What are those really critical early signs, the red flags, that make them think, hold on, this could be MNOE?
Yeah, that's the key distinction, isn't it? While it might begin looking like a standard diffuse otitis externa, the major giveaway is the pain. And we're not just talking about discomfort. This is described as excruciating, unrelenting pain. Severe. And then when a doctor looks inside the ear, they'll often find something called granulation tissue. It looks like small, reddish, kind of lumpy areas, especially right at the spot where the ear canal cartilage meets the bone. That combination, severe pain plus granulations, that's classic.
Wow, okay. Excruciating pain, that alone sounds like a massive indicator. But then you mentioned it doesn't just stay in the ear. What happens next? How does it actually spread? That's what makes it such a deep dive issue, right?
Exactly. Here's where it gets really concerning. What makes MNOE stand out is its alarming ability to spread way beyond the external ear canal where it started. It just doesn't stay localized. Actually, facial paralysis is a surprisingly common early symptom.
Paralysis from an ear infection.
Yeah, it signals the infection has already started messing with critical nerves, like the facial nerve. And from there, it can invade really crucial areas. Think the base of the skull, the jugular foramen. That's a key opening where vital nerves and blood vessels pass through. And when that happens, you can get multiple cranial nerve palsies, affecting things like swallowing, maybe speech, even eye movement.
Okay, that's serious.
It is. And the spread doesn't stop there. Anatomically, it can move forward anteriorly into the area around your jaw joint, the temporomandibular fossa. It can go backward posteriorly to the mastoid bone, that big bump behind your ear. And it can go medially deeper into the middle ear space, and even the petrous bone, which is this really dense bone right at the base of the skull. So this deep, extensive spread. That's why it's not just some surface-level problem. It's invasive.
Right. That aggressive spread really underlines why getting an early diagnosis is just absolutely critical. So when a clinician first sees a patient, what are those initial clues that just scream, hang on, this isn't your garden variety ear infection?
Well, the suspicion usually gets triggered by the patient profile and the main symptom. Typically, it's an elderly patient, often diabetic, presenting with really severe ear pain, what we call otalgia. Combine that severe pain with finding that granulation tissue in the outer ear canal, especially right at that junction between cartilage and bone. That combination is a very strong pointer towards MNOE. Those specifics, the patient type, the pain level, the granulations, they really raise the alarm.
And once that alarm bell is ringing, what about imaging? You mentioned scans earlier. What role do things like CT and MRI play? What do they actually show?
Imaging becomes absolutely vital then, yeah, to figure out the full extent of the problem. CT and MRI scans, they're used to see if the infection has started to destroy bone. Bone erosion is a key sign of MNOE's aggressiveness. And they also show how much the soft tissues around the ear canal and deeper structures are involved. They basically give the doctors a detailed map showing exactly how far this infection has managed to spread.
Okay, so standard imaging gives you the map, but you also mentioned something really interesting, a contrast between two specialized nuclear scans. What do those tell us? And why is the difference between them so important clinically?
Yes, this is a really neat clinical point. There are two main nuclear medicine scans used here, gallium-67 and technetium-99. The gallium-67 scan is pretty useful both for the initial diagnosis and for monitoring how this treatment is working. See, gallium gets taken up by specific immune cells, monocytes, and reticuloendothelial cells, which are active in areas of soft tissue infection. So it highlights active inflammation. And the key thing is you can repeat it, say, every 3 weeks or so. This gives doctors real-time feedback. Is the infection calming down? Is the treatment working?
Okay, so gallium shows active infection and you can track progress. What about the other one, technetium?
Right. The technetium-99 bone scan is different. It does show if the bone itself is infected or inflamed, but, and this is the crucial difference, it cannot be used for monitoring treatment response.
All right.
Because even after the infection is completely cleared up, that bone scan can stay positive for a year, sometimes even longer. So it tells you if bone was involved at some point, but it doesn't tell you if the infection is currently active there.
Ah, I see. So for tracking treatment, you need something that reflects current activity, like the gallium scan.
Exactly. That's the key insight for managing treatment. You need a tool that shows active disease, not just old damage.
Okay, makes sense. So once you've got the diagnosis confirmed, mapped out the spread, how do you actually fight back against this thing? What's the treatment strategy?
Well, the sources lay out a sort of three-pronged approach. All components are really essential for getting a good outcome. First, and this is absolutely fundamental for diabetic patients, is getting their diabetes under tight control, aggressively. Uncontrolled blood sugar just fuels the fire, makes recovery much harder.
Right, got to manage the underlying condition. What's next?
Second is what they call toilet of the ear canal. Sounds a bit odd, but it basically means meticulous cleaning. Removing all the discharge, any debris, scraping away that granulation tissue, maybe removing any dead tissue, debridement. This helps control the infection locally and also lets the antibiotics penetrate better.
Makes sense. Clean the area up. And the third part must be antibiotics.
Absolutely. Targeted antibiotic treatment is the third pillar. It has to be aimed squarely at the usual suspect, Pseudomonas aeruginosa, and ideally guided by culture and sensitivity testing done on the ear discharge. You want to use the right weapon for the specific bug.
Let's dig into those antibiotics a bit. The information you shared mentioned a few specific types and some things to watch out for, like gentamicin combined with ticarcillin was noted. What are the issues there?
Yeah, with that combination, there are definitely things to keep in mind. Ticarcillin is a type of penicillin, so it can cause penicillin-like allergic reactions in susceptible people. And gentamicin, well, it's a powerful antibiotic, but it carries warnings. It can be ototoxic, potentially harmful to hearing, and also nephrotoxic, meaning it could damage the kidneys. So careful monitoring is needed.
Okay, so potent, but with potential downsides. What other options are there?
Other effective choices mentioned are the third-generation cephalosporins, things like ceftriaxone or ceftazidime. These are usually given intravenously, maybe 1 to 2 grams a day, and often they're combined with another type, an aminoglycoside, just to ensure really broad coverage against the bacteria.
Right. And beyond those IV options, you also mentioned quinolones. And from what I gather reading this, these were kind of a big deal, weren't they? They really changed things.
Oh, absolutely. Quinolones were a major step forward. Drugs like ciprofloxacin, ofloxacin, levofloxacin, they're highlighted as being very effective against Pseudomonas, and here's a game changer. They can be given orally, by mouth. Ciprofloxacin, for instance, is often prescribed as maybe 750 milligrams once a day, taken as a pill.
And the big advantage there is...
Huge advantage. Oral therapy means many patients might not need to be admitted to the hospital just for IV antibiotics. They could potentially be managed as outpatients, which is obviously much better for the patient's comfort, convenience, and it reduces healthcare costs, too. There's a really significant shift. Now, sometimes, despite the initial treatment, a patient might not respond as well as hoped. In that situation, the strategy involves going back to basics. Reculturing the ear discharge, doing detailed sensitivity testing becomes absolutely critical. Those results will then guide the doctor, maybe point towards a different antibiotic, or perhaps adjusting the dose, or how long the treatment needs to continue. And, if we sort of step back and look at the bigger picture here, it's quite interesting to see how treatment has really changed over the decades. Historically, MNOE often required quite radical surgery, major resections of bone. But now, prolonged, carefully targeted antibiotic therapy has largely replaced that aggressive surgical approach. That really speaks volumes about how much medical management, especially with antibiotics, has advanced.
So, okay, let's try and wrap this up. What does this all mean? We started with, what seems like a simple earache. And we've taken this deep dive into malignant or necrotizing otitis externa, a condition that really turns that simple infection into a major medical battle. We've looked at who's most vulnerable, how it can aggressively spread through really critical parts of the head and neck. We've touched on the smart diagnostic tools from clinical signs to specialized scans, and how treatment strategies have evolved, becoming less invasive but still requiring long-term commitment. It really shows, doesn't it, how digging into these seemingly niche topics reveals so much complexity and also so much ingenuity in how medicine tackles these challenges.
Absolutely. And maybe it leaves us and you listening with a final thought to ponder. Despite all these incredible advances in diagnoses and these powerful antibiotics we now have, what are the challenges that still remain, especially when managing such a persistent, aggressive infection in these vulnerable patient groups like elderly diabetics? What future refinements might we see? How can we continue to balance hitting the infection hard, the efficacy, with the overall burden on the patient, especially now that we've moved away from radical surgery towards these sometimes very long courses of medication? What comes next?